Hi, my name is Sarah Levy. I am a first semester junior majoring in biochemistry with a minor in health and wellness at the University of Oswego. In today's video, I will be discussing how socioeconomic status influences determine cardiovascular disease and its risks. I have chosen to discuss this primarily due to the fact that cardiovascular disease is one of the leading causes of mortality or death in the United States. On that note, throughout this semester, we have dived headfirst into what and how socioeconomic factors influence those who fall under low income and racial disparity. In particular, in my study, the difference in cardiovascular disease among the white and black populations and how their socioeconomic facets play a huge role in the likelihood to survive and sustain health. So throughout American history, medical health care has been treated as a market commodity, meaning not everyone could afford general health care. Although the Affordable Care Act is intended to make health care more broadly available to those without access to affordable health insurance, there is a lot of hesitation from many states to expand Medicaid eligibility because ultimately it will mean that low income and poor individuals may still have to go without access to affordable care because many racial and ethnic minority groups, especially blacks and Hispanics, have substantially lower socioeconomic status on average than whites and Asians. We generally expect those same groups to have lower ability either to obtain health insurance or to pay for care directly. But it is important to acknowledge that it's not only about affording health care. Some factors that play a role in not being able to afford or obtain healthcare also includes the understanding of the healthcare system capacity, which includes a number of available physicians and the characteristics of the local hospital, for example, the sanitation, and lastly, the availability of other types of local healthcare facilities. This coincides with many of those who are subject to be suffering from health disparities, but can do little to solve them. I would also like to highlight a huge factor that influences care among races with health disparities in the level, capacity, and kind of care and treatment they receive. So, for example, in Chapter 7 of our reading, a study conducted by Winaya and colleagues in 2007 examined the records of 320,000 patients who received care from 123 different hospitals, assessing the quality of care received based on 13 established measures of clinical quality. They concluded that the minority patients, defined as Black, Hispanic, or Asian, experience a lower quality of care while in the hospital than non-minority patients, and that hospital that served a larger proportion of minority patients tended to be lower in quality than those seeing more non-minority patients. Continuing, another study conducted by Joint and colleagues in 2011, which I've been researching for my final paper as well, took a look at the quality of hospital care received by elderly Black and white patients on Medicare, who received treatment for one of 3 serious conditions, including heart attack, congestive heart failure, or pneumonia. So for their measure of quality, they determined which patients needed to be readmitted within 30 days of a discharge for treatment of the same problem or a different health issue. Interestingly enough, they found that Black patients were more likely to be readmitted than white patients, and that being treated in a hospital serving mostly minority patients rather than a patient's race was the principal factor explaining the quality disparity. This hospital care amongst Black patients also correlates with their treatment in nursing homes. And there's a strong inverse correlation between the percentage of Black residents in a nursing home and the quality of care in that home. The more racially segregated patients in a home, the lower the quality of care provided in that home. It's clear that some do care about this and are trying to do their best to restore this. It is apparent to the IOM, the Institute of Medicine, committee that racial and ethnic disparities in healthcare are a national problem that requires a change in national policies to address them. The committee recommended that the federal government support the systematic gathering of data on patterns of care so as to monitor the levels of racial and ethnic disparities that exist and to conduct further research on issues surrounding the reduction or elimination of those disparities, especially in racial and ethnic groups. As part of this initiative, the U.S. Department of Health and Human Services amended amended a goal of its Healthy People 2010 initiative, a national initiative to set goals for the improvement of the health of the American people, to include the elimination, not just the reduction, of health disparities for all minority groups, including African Americans. So in 2011, the government expanded this effort with publication of its Action to Plan Reduce Racial and Ethnic Disparities. Congress also directed the U.S. Agency for Healthcare Research and Quality, AHRQ, to prepare a yearly health disparities report. In my opinion, I believe that future programs will have to really focus on the physician rehabilitation aspect, meaning training all incoming and standing physicians on the racial inequalities and treatment of such, and how to avoid improper behaviors of racial bias, stereotyping, prejudice, and clinical uncertainty on the part of healthcare providers, which may contribute to racial and ethnic disparities in healthcare and deepening health disparities with Black patients in America.